I'm very happy to be for first time here in your meeting and your conference, and I will explain my vision about breast IURT and the policy that we use in our department and our center in Barcelona, in Spain. I will speak about these 7 points. The first 2 points are about concepts, the third one about our policy after clinical experience that we have in a new clinical trial. Finally, we'll speak a little bit about our lab research that we are doing in our department, and finally the conclusion. First point, about high doses in radiotherapy. I think this is perhaps a very simple point, but I think it's important to know, that is my opinion, that IURT is similar to SBRT and is similar to brachytherapy with high-dose rate brachytherapy. Why that? Because if we take into account the definition of SBRT, we see that SBRT is very high dose per fraction, few fraction, very precise treatment, and a rapid dose fall-off of the dose into the tumor. And this is a clear definition of SBRT, and everybody agrees in the definition. But if we take a look about brachytherapy with high-dose rate brachytherapy, the definition is very similar. We are doing a few sessions, high doses, probably less than IURT. The doses in brachytherapy are going from 5 more or less to 15 grays, then less than IURT. We have also precise treatments, that is also very important, and the dose follow-up that is going the same way than SBRT. But with 2 advantages with brachytherapy. With brachytherapy, you have lower integral dose, first of all, and the second one, I think we have longer experience than SBRT. And finally, our topic, IURT. If we take also a view of the definition of IURT, it's exactly the same. IURT is only 1 session. We are doing a very high dose, 20 grays or more. We have a very precise treatment, that is also very important, and we have the same rapid dose follow-off that we are using in our patients. But again, with some advantages, the low integral dose in comparison with external RT. We have also the treatment in only 1 shot, surgery plus IURT, plus the radiation therapy, and we have the guidance by the eye and by the fingers. Then in theory, it seems that they are very different, these 3 types of treatment, but at the end, the main rationale for these three treatments are exactly the same. And I think this is very important for the next things that I will explain to you in my short talk. Second point, the potential advantages. I think this is, as a concept, I think this is very clear. There is no doubt about that. IURT and brachytherapy, we have a low integral dose in comparison with protons, with external RT, with SBRT, what you want. And the second very important point, I think it is that the moving target is not a problem for IURT. You can use our SBRT, very precise, was the best image-guided radiotherapy, but always the target is moving, even that you have the best image-guided radiotherapy. But with brachytherapy, but in particular with IURT, the moving target is not at all a problem for us. Policy in our hospital for IURT in breast cancer. I think it's very important, this point, because I come from a cancer center who has 3 different hospitals located in a region in Spain that is called Catalonia, that is located in the south of France. This is the boundary with France. In our region, we have 7 million of inhabitants, and we treat at the cancer center, in these 3 centers, we treat more or less 40% of the population in our region, in our country. And why is important that? Because see the numbers that we treat. With 11 linacs, we treat 6,000 patients with external RT. You see the difference, 5 linacs, 3,000, 1,400, and 106,000 with this number of linacs. But see at that, we are treating a lot of brachytherapies in our department, more than 1,000 treatments. We are treating radiosurgery, these numbers, and IURT with breast, with IURT, 60 patients. But these numbers are important. And why are they important? Because we treat more or less 50% of those patients for gynecology, 20% for prostate cancer for brachytherapy, and 15% for brachytherapy to breast. Then we decided in the department to begin with IORT in breast. We have to discuss all together in the sense to see when can we use IORT and when can you use brachytherapy. And then we review the literature and we see what you have explained. Excuse me, when you have explained, there is a miss. Exactly here. What you have explained before, Jay explained that, we have reviewed that several times. We saw that when you are doing IORT in this Target A trial, when you are doing IORT post-surgery, the local relapses are more. But when you do the IORT in the same moment of the surgery, local relapses are the same. Then what we did in the department, we decided that when the patient is operated in another hospital and is referred to us to do external RT or brachytherapy, in those patients who are good candidates for partial breast irradiation, in those patients we perform brachytherapy with high dose rate. And in the patients who are operated in our center, and those patients who are in the surgery with Dr. Achuspla, who is here in the room, they are operated in our department, then in those cases we decided to do IORT. Then we think that there is no competition at all. It's a complementary treatment that you can choose for some of those patients brachytherapy for partial breast irradiation and some of the patients for IORT for partial breast irradiation. And they are, that's very important, not competitive. We can collaborate and we can give to the patient the best treatment and the most personalized treatment for the patient. And this is good for us because we have participated in the JEC-ESTRO phase 3 trial for brachytherapy. We included 100 patients, and we can explain to everybody, people doing brachytherapy in breast and people doing IORT in breast, that you can combine one or the other treatment depending on the characteristics and the schedule that has the patient. And this is our policy, and in our mind, there is no competition, there is complementarity in between IORT and brachytherapy. Next point, clinical experience. When we begin to do IORT for breast, we think about, the Target A trial was finished, we think about what we can do as a clinical research. And now we are doing the papers to entrance in the Target B trial. But the point is, we decided in our department there is a lot of tradition that Dr. Achuspla will explain tomorrow to you about oncoplastic surgery. And then we decided in the department, with the surgeon department, the radiation oncology department, to do a phase 2 trial doing conservative surgery with or without oncoplastic surgery. And after that, IORT at the same moment. And after that, external RT with hypofractionation. We begin this trial, 2 centers, my center, Radiation Oncology Department at ICO, and the Hospital de Bellvitge Surgery Department also at Barcelona. And we begin this trial, and we are working a lot with the French in the south of France, from Toulouse, Montpellier, and Marseille. We are thinking with them to include them also in this trial, because this trial is for a short number of patients, but I think it's important to try to have the maximum number of centers participating in this trial. And, excuse me, but that's right. And then in this trial, we are doing the cosmetic, we are evaluating the cosmetic results, the local control, and the survival. We want to include in the trial, like you can see here, 64 patients, and until now we have included 21 patients. And again, the protocol of this trial is surgery, oncoplastic or not, plus IORT, 20 grays to the surface of the applicator, plus a hypofractionation, 15 fractions of 2.76 grays per fraction until a total dose of 40.05 grays in total. This is our trial. We are ongoing at the moment. We are including patients in our trial. And finally, I will speak a little bit about biology, the lab biology, that I think is a very important topic that we have to work in the future. Think about, I am a clinician, I am not a biologist, I am a radiation oncologist. Then what the information that we give to you probably will be at the same level than you, because the majority of you are clinicians. And then what we have in biology for IURT in breast, we have, Jay explained that very well. We have the experience of the group of Novara in Italy with Gustavo Baldassarre. They have published a lot of things, and they have studied in particular the fluids after the surgery. And they have published in that paper in 2000, like you can see here, 14 in molecular oncology, they have seen and published that there is two pathways of those proteins, P70S6K and STA83, that can explain that those proteins are liberated in the moment of the surgery, and these proteins stimulate the growth of cells, probably also tumoral cells, but normal cells. And the reason that IURT is going so well in those patients is because IURT is destroying these proteins and avoid the increase of cells. This explanation for him, for Gustavo Baldassarre and his team, why we have so good results using IURT in breast cancer. This, I think, is one very important group doing research, lab research in IURT. And what about our group? In our group, when we begin IURT in breast cancer 3 years ago, we begin to think what we can do for lab research. We spoke with Zeiss, in particular with Brigitte Both, the medical director of Zeiss, and we proposed to him one project that we have. We know nowadays that everybody is speaking about immunology. You know about chemotherapy and immunology, new drugs of immunology, etc. There is a lot of papers also speaking about the effects of SBRT in immunology. There is some papers, but not really a lot about IRT and immunology. In our point of view, we began then to study what the effects of high doses, SBRT, brachytherapy, and IURT, in the response, immunologic response of our patients. And in particular, going to IURT, we decided, in conjunction with this grant that we have, we decided to study what happens in those patients if you give a very high dose with IURT, 20 grays, before and after these very high doses. And our question was, there is a stimulation of immunity after these very high doses using IURT. And then this was our hypothesis, and this was the primary objective, to see if there are changes before and after IURT. This is the study that we did. 3 arms, like you can see here. First arm, the standard one, in luminal A cases, the best cases that we have. Surgery plus IURT, no more than that. Second arm, surgery plus IURT. And if we have in those patients bad local prognostic factors, like lymphovascular invasion, grade 3, extensive intraductal component, etc., in those patients, we add external RT hypofractionated, 15 fractions at 2.67 grays per fraction. And finally, a third arm that is the control arm, surgery plus hypofractionation radiotherapy external RT. And then in all of those patients, we did a blood sample before surgery, a blood sample 2 days after IURT, a blood sample 3 weeks after IURT, or 2 days after external RT, and a blood sample after 3 weeks, and a blood sample after 10 weeks. And this was our idea, to know if there is immune changes after the IURT, the very high doses, having the control arm as a reference. And then what we did in this research, we did the flow cytometry analysis that I will present now. I only present the flow cytometry analysis at 3 weeks. We do not have the results at 10 weeks. These 10-week results will be presented in the IORT meeting in Mannheim in July, and this will be presented by my colleague, the colleague in my department who is both radiation oncology and biologist, and she will present these final results of this study. And we have done the phenotype, the flow cytometry analysis, 3 weeks, and with these panels that you see here, phenotyping panel, and in particular, we want to study the CD8 cells. After that, the panel for natural killer cells, that also is very important, the regulatory T cells panel, and finally the myeloid-derived suppressor cells, the MDSC panel. What we hope to see if there is a stimulation of immunity. We have to see if there is a stimulation that we will have an increase of CD8 cells, we'll have an increase of natural killer cells, we will have a decrease of T regulatory cells, and we will have a decrease of MDSC cells. See what happens in our study at 3 weeks, not at 10 weeks, at 3 weeks. We have included in our study, we have to include 15 patients per group. We have included 8 patients in the group A, only IORT plus surgery, group B, surgery IORT and hypofractionated A patients, and in the group 3, that is only external RT, hypofractionated, only 1 patient. Why that? Why we have this problem? Because when we have to do an IORT, we see before the surgery the patient. When the patient is going for a surgery and after external RT, we do not see the patient. We are trying to modify this network because we have to see the patient before, because we need the blood sample of those patients before the treatment. We are organizing that at that moment. And until now, 15 has to be included here, 15, 15, and 15. We have 17 patients with this proportion that you can see here. What we find in our study, we find that, again, I am a clinician, I am not a biologist. I will try to explain simply that I understand and I can speak to you. You can see here is the group A, only IORT. Group B, IORT plus external RT. Group C, only 1 patient, is only external beam therapy hypofractionated after surgery. You see these lines as each patient. Here you have 8 lines, here you have 8 lines, and here you have only 1 line. What we have seen in the first panel, the panel of the CD8 cells, we have seen that there is an increase of CD8 cells in the panel of the group A, in the group of only IORT. But there is also an increase, but not so important, in the group of combination of IORT plus external beam radiotherapy. Then, first conclusion in this first panel, at 3 weeks, there is an increase for this particular CD8 cells in immunology, immune response, excuse me. Second panel about natural killer cells, group A, group B, and group C. This is probably the most important results that we have at 3 weeks. You see that for group A, only IORT, in all the cases there is an increase of natural killer cells. There is also an increase at the end at 3 weeks for the combination of IORT plus external RT. And we cannot say anything about only 1 patient because you see there is a very big difference in between the beginning and the end of the treatment. Then this is in favor that IORT again is stimulating the immunity of our patients for breast cancer. Third panel, the panel for Treg cells. What we have to find in that panel, a decrease in these Treg cells if we think that immunity is increased using IORT in breast cancer. What we have found that in group A, again, we have a decrease in the majority of patients at 3 weeks, that going in favor that this increased immunity, the IORT. You see that it's not very clear in the combination of IORT plus external RT, and there is a decrease in only 1 patient, in the patient who has only received external RT. And finally, the fourth panel, the panel for the MDSC panel from the myeloid cells, what we think we have to, if there is a stimulation, these cells has to decrease. And what we found in general, there is a decrease in group A, IURT, at 3 weeks. There's a maintenance or increase in the group of combination of external RT and IURT, and there's not clear in the group of only external BMRT. And then what is the conclusion for this particular study? And these are only initial results. The conclusion is that probably IURT is stimulating the immune response of the patients, and this response of stimulation is from 2 days after IURT until 3 weeks after IURT. We don't know at 1 month, at 10 weeks, at 10 weeks. But the conclusion is that IURT is stimulating the immunity of the patients that you treat. And finally, conclusions for this short talk is the following. I think we can say that first of all, we agree, all of us, that we need longer follow-up in the trial, the Target A phase 3 trial. This is clear, but this we will have to wait for a few, probably less than 1 year. The second one, we have to do more and more clinical research with new clinical trials that has been presented previously. Third point, I think that it's important to do more and more lab research. Why that? Because to emphasize, to support IURT in breast cancer in front of our colleagues doing SBRT or doing classical radiotherapy for breast cancer, we need theoretical basis to say to them, this is the right way to go, because this is stimulating immunity of the patients. And the last conclusion is, we don't have to see brachytherapy and IURT for breast cancer as competitors. They are complementarity. They have complementarity treatments, because you can personalize the best treatment, brachy or IURT, depending on the characteristics, where the patient has been treated, if the patient has been operated before IURT, etc., etc. And then again, we have to personalize and to do complementary treatments with one and the other, external IURT and brachytherapy.